All right. Well, everybody, welcome. I'm Scott Fields, and I have with me today Mike Johnson. We've I'm a psychologist from family medicine as I load my slide here. And Mike and I were former colleagues at WVU, and now he works for Grant Family Medicine Center. And we've sort of, for several years, kind of done some 1-2 punch here at the forum with psychology and family medicine, as Mike is a family physician. And today what we wanted to talk with you all about was PTSD treatment, specifically how to do trauma-informed care in family medicine. Of course, we also capture referrals and, when we can't, types of treatments that we may not be able to pull off as well in family medicine. But for the most part, what can we do to practice in a way that's more trauma-informed? And the first thing I'll say is that both Mike and I have nothing to disclose as far as financial interests. We both work for our respective departments, and nobody else, although I do at times do odd jobs for my wife, but that is off the books, and that usually involves me messing something up in the house. But moving forward, our objectives, we want folks to learn how to assess and diagnose PTSD in the clinic setting using trauma-informed strategies. We'll talk a lot more about that and a lot more about some of the things that I've learned in the last couple of years as I've tried to adjust my skill set. Participants will also be able to list non-pharmacologic treatment strategies for PTSD. I know what I see a lot in primary care is folks wanting a certain medication when they come in with post-traumatic stress. And as Dr. Johnson and I will talk about, there are a lot of treatments that are not medications that are quite helpful and long-lasting for patients. And then also, participants will increase their understanding of the latest literature on evidence-based pharmacologic management of PTSD symptoms, and Mike will be talking quite a bit with you all about that. So we'll start with an overview, and then we'll go into assessment and treatment. So we have basically 3 parts here. Think of it as a trilogy, right? And that'll get you excited. So I won't bore you too much with the DSM, because I know that by now most of you have carried this purple book around with you for the better part of a decade. But just be aware that post-traumatic stress disorder is in that category of trauma and stressor-related disorders. And its kind of close cousin is acute stress disorder, which is essentially similar PTSD symptoms, but just for a lesser time period. And oftentimes folks with acute stress disorder sort of graduate up to PTSD when they meet the duration criteria. Those other diagnoses are relevant in a sense, but not so much relevant to our discussion today. And again, I won't bore you by going word for word through these PTSD criteria, but I will kind of talk about what I think are the pertinent parts here. Now, the first thing I think about with part A of PTSD diagnosis is that it's exposure to actual or threatened death, serious injury, or sexual violation. So in other words, we can have folks who had their lives threatened or they were exposed to someone else's life being threatened or being violated in a certain way. One case that I'll call up, and I've changed some of the details, but I have a patient that I've been working with who is rather a 9/11 survivor, and I've changed some of the details because frankly there aren't a whole lot of 9/11 survivors in the state of West Virginia, so I didn't want to out this individual, but certainly in her case she witnessed death, and that was part of her criterion for part A. But also, unfortunately, over time, as we've learned, folks in the 9/11 community, she has also had some serious health issues that she and her medical team believe are related to exposure there. So, uh, so I will bring that case up. I just wanted to kind of introduce it a little bit now, and we'll call her Kylie throughout today's lecture. So, um, the event can occur to others, as I mentioned. It could be to someone people know or someone folks don't know. And, you know, there's repeated exposure. We see this a lot in soldiers, first responders, police officers, so on and so forth. Um, Incidentally, one thing at the bottom that it doesn't necessarily, we all in this time of electronic media, we'll sometimes see disturbing images and so forth on our internet or television. That does not apply to this diagnosis. So I'll turn it over to my colleague, Mike, for a deeper dive into criterion A.
All right, so with PTSD, we're talking about that exposure, and we're going to just kind of look at some of the things that we may see our patients who are coming into the office, some of the things that they have experienced. Now, one of the more common ones are motor vehicle accidents. About 25% of males and 13% of females have been in a motor vehicle accident of significance, and 3 million injuries annually. Now, I have a patient that I see in the office that this was, she has very significant PTSD where she wrecked her car, was ejected from the car was overturned, and then her 1-year-old was strapped in a car seat in the back. And because of issues going on with storms in the Columbus area, she was laid out being attended to by people for about 45 minutes before you know, anything happened to get her kid out of the car or to get her to the hospital. And she had significant injuries that are still affecting her today. So about 9% of motor vehicle survivors will develop PTSD. So this is a very, very common issue for those after a motor vehicle accident. PTSD is about 60%. So one of the things that we're going to talk about today as well is that in these folks, about 50% have some sort of pre-existing or coexisting diagnosis that we can usually account for. And in my patient, after, you know, I've been seeing her now for 10 years, there was not the greatest of a home life growing up, and I think that sort of set her up, and then the motor vehicle accident she was in was the one that tipped the scales. And we're now 10 years out and still daily dealing with some of those things. Next slide. So one of the more common ones that we have always, you know, associated with PTSD is combat. And, you know, this was that shell shock of the World War II veterans that came home, and we saw a huge uptick in what we then realized was PTSD among those that returned home from the Vietnam War, about 15%. And this is then where the VA has really taken the reins for treatment, and really where you will find a lot of the top-notch information. Now, one of the things to also bring in has to do with women in the military. So, you know, we do have women being exposed to combat, but also for women in the military, it is a place that still is working through a lot of issues as women are joining the ranks of the military with sexual assault, as well sexual harassment that occurs in the military. So this is another one that we must sort of keep in mind as we see patients, and especially for females that have been in the military. So as Dr. Fields was talking about, you know, the event, and this is really one of the events that you will see results in high rates of PTSD, and that has to do with sexual assault. And for, you know, rape, about 20% of women, about 1% of men. This is something that we're going to find in their history or with sexual coercion. About 13% of women and 6% of men. And again, in the day of the internet, some of this even is getting more prevalent. So one of the things to think about as well for women who are raped, half of them, this occurs prior to age of 18. And we will talk about that as we talk about adverse childhood events. So for our patients that we are seeing, you know, who commits the sexual assault or the rape, this is not one of those where we have the rapist, you know, comes in the night and rapes and off they go. That this is typically 80 to 90% of those people are known. And we also see that this also occurs within family settings or with intimate partners. So what we have is a issue of a chronic exposure, and we can kind of get into that as we go along. So one of the other ones I did want to mention before we kind of move along also is climate events. There's been some discussion as well. 2020 has been a very rough year for many, many reasons, and climate events, although not as likely to result in PTSD, but they are clearly increasing. Anyone living along the Gulf Coast, anyone living out west, you know, Seattle has become Southern California as far as a fire season anymore. So we are looking at climate events as well, although less likely to result in PTSD, but they do occur. So one of the ones, and this is something that we've had a discussion among the faculty here where I work. We're in a downtown urban environment. We service 2 zip codes that are have some health indicators and quality of life indicators that are very, very difficult. And this adverse childhood experience is something that we've been discussing about, because it is something that we are beginning to recognize among our patients, that, you know, the emotional and physical sexual abuse that some of them have endured in their childhoods, and now they're adults, we are seeing them, and it really, really complicates a picture of what we're doing for our patients. Now, one of the most difficult is, and it kind of goes unrecognized, is emotional neglect, because there's not any type of physical assault or sexual assault, but emotional neglect is also a very, very tough one. And then as we are in 2020 dealing with an opioid, people's households are under strain, we are seeing, you know, drug use, we are seeing divorce, separation, all of these things affecting families, affecting children. I have patients who I'm treating that have, you know, bipolar or other illnesses, and you talk to them, and this is something that has just been running in the family and has never been addressed. It's sort of that perpetual trauma, generation after generation, that does not get addressed. And then family members who imprisoned and causing a breakup of families. So what kind of things do we see then sort of downstream from this? Like I was talking about, you know, we have our patients that we see here in the office, and, you know, we have very, very difficult medical issues that we are dealing with. We have very, very difficult sort of mental health issues, and what these adverse childhood experiences result in this downstream issues that we see. And we see mental health problems, we see drug, alcohol abuse later in life, but it also has medical consequences as well, from heart disease, stroke, cancer, COPD, diabetes, Alzheimer's, and suicide. And with suicide is number 4 PTSD is number 4 on the reasons for suicide. So it is something that we see sort of in that downstream effect that is going on. So looking at, we have an addiction medicine program here within our department. We have a fellowship. So we have an addiction medicine team, addiction medicine clinic, and we all kind of intermingle. And this is something that is very, very common that we see has to do with our patients treated with opioid disorder. So what we find is that for a lot of these folks, these adverse childhood events are sort of that spark that then later in life, and we find that the opioid abuse then is sort of a result of what's going on. So with each of these, adverse childhood experiences, we get increases in relapse rate. We see even first visit high rates of relapse. And this also, so the long term is it complicates the care. So I mentioned about our rural patients, and this is something that actually I was reading about recently, is a bit of a suicide epidemic that is going on in rural America right now that seems to, with our coronavirus and the things going on has increased. And we're seeing among our rural residents that we have some higher rates of opioid abuse. We see the opioid abuse occurring at a younger age. And we have a lot of access of care issues and, of course, finances and insurance to get these patients treatment. And the other thing that we have among our rural residents, and Dr. Fields and I spoke about suicide a couple of years ago, is the fact that in rural America, our guns are everywhere. So the people that are dealing with mental health issues and dealing with these childhood experiences then later in life with opioid abuse, that suicide is definitely a huge, huge issue.
All right, thanks, Dr. Johnson. I'll be doing part B and talking a little bit about that part of PTSD overview. As we think about this, I think Dr. Johnson brought up a good point, and that is that generally speaking, most of the folks that I've worked with do not have just the one traumatic experience. It's often repeated experiences. For example, Kylie, who I mentioned earlier, the traumatic event that sticks out the most is that she's a 9/11 survivor. But prior to that, she had experienced some sexual assault on at least 2 occasions that I recall as like a teen and young adult. And so what this does, I think, is sometimes just multiplies the previous trauma and sort of, I think now you have different stressors or different situations that you can have. Some of these things in part B that I'm going to be talking about, that is sort of re-experiencing or intrusive thoughts about traumatic events. These can be memories, these can be dreams, these can be kind of flashbacks or dissociative episodes, and folks will have this sometimes out of the blue, but sometimes because of an internal or an external kind of stressor or cue, and there can be a marked physiological reaction. It wasn't Kylie, but one time in my treatment with a patient who had been diagnosed with PTSD, it was sort of a day like today where you can probably see behind me, it gets light and then it gets dark. I have a window behind me. It was one of those days and the sun started hitting me right in the eyes and I was talking with this patient and I got up to put the blinds down and this patient immediately like jumped back and kind of got away from me in her chair. And again, that was just an automatic kind of response to this cue that a man kind of quickly got up, and I've learned that I will now say to any patient, is it okay with you if I get up and close the blinds? And I think that kind of demonstrates part of what we're going to be talking about today with trauma-informed care. So looking at part B a little further, as Dr. Johnson pointed out when we were talking about ACEs, these adverse childhood experiences, and then certainly PTSD type experiences, can cause a lot of different issues with attachment and relationships. And so folks can have very volatile relationships, very hot, cold, difficulties establishing supportive friendships and romantic relationships. And certainly that can make it tough for us as clinicians. Sometimes folks with a difficult past can be difficult to know, can kind of on the exterior be, one of my interns said, prickly, just a little bit, tough to get to know and react a little more, I guess, in an irritable fashion or something of that nature. But I do think also that when you connect with someone who's had this kind of past and can start helping them, that can be a very life-changing relationship for them, and certainly can be a very good relationship for us as clinicians to feel like we're connecting with someone who's had these kind of adverse experiences. Physical health, as Dr. Johnson pointed out, a lot of folks with adverse childhood experiences will be more susceptible to a number of health risks, including some immune issues early on, a stress response out of proportion with the typical person, and then more chronic kind of health conditions later in life. This can impact the way people respond emotionally. Again, people have a difficult time expressing themselves. You will also sometimes meet folks who engage in non-suicidal self-injury because they have just such big emotions that's very difficult for them to express in other ways. Limited capacity in some cases for putting their emotions into words. And this will dovetail pretty nicely with some of the treatments we'll be talking about as far as how to help folks make those changes. And of course, you see certainly more mental health problems with folks who've had trauma earlier in life. Behaviorally, as I pointed out earlier, folks can be irritable, can have difficulty regulating their behavior, could also be detached. Some folks who've had trauma will not want to get close to anyone, perhaps out of fear of being hurt again, or just the effort that it takes, so on and so forth. And as Dr. Johnson pointed out, you can have some risky behaviors and substance use. Cognitively, my neuropsych colleagues will often do an evaluation for me, and what we'll often see is some issues with executive functioning, and even particularly when compared to prior to the trauma, some differences in IQ. And I just again think that trauma and the emotion and so forth and the cognitions that go with it take up a lot of mental energy. And so I think that can play a role there. Folks younger on can have deficits in language development if they've had early traumatic experiences. And then folks will have this sense of foreshortened future, diminished self-accomplishment, shame, guilt, worthlessness, etc. later in life. I like to think about this, and this is certainly I got this from the trauma-informed care stakeholders, so it's not our graphic, but I like to think of what we see with early death as kind of the tip of the iceberg. So a lot of folks who die of, say, substance use disorder or a heroin overdose, something of that nature, will have all these things kind of under the tip of the iceberg. They may have had these adverse experiences, some disrupted neurodevelopment early in life, all these kind of social, emotional, cognitive impairments, may have had high-risk behaviors, excuse me, and then leading to disease and so forth. So I guess I like this slide because it lets us know that health and mental health problems don't just happen in a vacuum. There's often a lot of history behind them, and in many cases that history is a history of trauma. Now, I'm not crazy about this word superutilizer, but I've seen it some in the literature. But that generally refers to folks who just use a lot of services and resources at your family practice and at your hospital. And what we found is people with 4 or more ACEs will often have more visits to primary care, visits to medical specialists, more emergency room trips, more medical symptoms, so on and so forth. Of course, higher healthcare costs, and even less productivity at work. And these are folks who, again, have these very difficult pasts. And I think, you know, probably 20 years ago when I started out, you know, kind of training in family medicine, I think there was maybe a more negative view of the folks who come in and out a lot. And I think that we have hopefully as a profession learned that there are reasons for this. There are reasons why folks keep coming back. They're suffering, and there's reasons why they're suffering. In many cases, it's because of the psychological distress from trauma. And so I think that we're approaching this in a much more trauma-informed way, and a much, even I've seen initiatives, I know our hospitals had them, that we will actually assign case managers to folks who they find are coming into the ER quite frequently. And we found that having someone who tags in to help folks with these you know, history of trauma can help in the long haul in getting their needs met, and also help in decreasing emergency room trips and things of that nature, kind of helping everybody out. So the pathways for trauma and illness, again, as you see, there's a number of them: physiological, behavioral, cognitive, social, emotional, and you can see some of the things. I'll just pick a few. Physiologically, we can see dysregulated levels of stress hormones in folks with a history of trauma. Behaviorally, again, as I pointed out earlier, we can see less safe kind of health behaviors, folks being less likely to wear seatbelts, for example, or folks smoking at a higher rate. Cognitively, folks will have more negative beliefs about self and the future. Socially as well, you can see some problems with relationships, and then emotionally as well. Of course, with depression and PTSD being fairly common. Well, now we roll on to assessment. So we've got a sense of this overview, and I wanted to kind of, since we have an interprofessional crowd here, I wanted to kind of look at the big picture, and not just PTSD from PTSD standpoint, but how it relates to overall health. And I hope that we were able to do that with that overview. But in terms of assessment, one of the things we think is the 4 R's, and this comes straight from SAMHSA. We borrowed a lot of information from the CDC and SAMHSA when Dr. Johnson and I did this lecture, as well as the VA, because we think all 3 of them have valuable resources. But the 4 R's are realization, recognize, respond, and resist re-traumatization. And I think this one is a big one: resisting re-traumatization, which, as I mentioned earlier, is a reason why I like to talk about what I'm going to do before I do it. And as a psychologist, I'm really not in people's personal space very often. And so I think we've certainly learned that this is a very good strategy for physicians as well, to sort of talk their way through an exam. So realizing, again, if I have to say, as the kids say, being woke, then it's probably not what the kids say anymore. I do realize that, but sort of being woke regarding trauma, I can feel my daughter eye rolling as I say that. Just recognizing that trauma is a big part of most of our patients, and kind of flipping the script. In other words, saying, well, I'll treat this patient differently because of trauma. No, let's treat every patient with the realization that many of them have had trauma, so that we don't have to kind of change how we work with folks who have that history. Recognizing, knowing the signs. We certainly know that there are gender, age, and certain settings that will elicit a gender and age of patients, and then certain settings that will be more likely to elicit trauma response. I know injections and OB-GYN kind of settings can be very stressful for folks who have had trauma or an OB-GYN kind of evaluation. Responding, applying the principles, we'll talk a little more about some of those principles later, but being able to respond when someone shows the signs of trauma, and not necessarily plowing forward with the clinical agenda when a patient isn't ready. And then again, like I said, there are more bullet points here because I felt like resisting re-traumatization. As I look back on my history of treatment, of treating patients, I've kind of seen situations where I unwittingly re-traumatized folks. And so being mindful of the environment that we create, making the physical environment as stress-free and non-toxic as we can. We want to enhance their recovery. And certainly our staff and how our staff treat patients and how they treat them and how they feel themselves is also important. So 6 key principles here. I said I would I whet the appetite, as it were, and said I would talk about those principles a little bit later. And those are safety, trustworthiness and transparency. So talking about what we're going to do and being very transparent about it. Peer support, in other words, having peer support both for us as clinicians, but also for trauma survivors. I think they can benefit from talking with other trauma survivors in certain settings. Collaboration and mutuality, everybody kind of working on the same goal. Empowerment, voice and choice. I love the phrase, see it, say it, fix it, if we see something that's not consistent with that. And then moving past stereotypes of, well, this is this kind of patient, so you got to be aware of this or that, and just kind of looking at individuals and being sensitive to their culture, race, and gender. I'll show you the website. I will click on that toward the end of this as well, where Dr. Johnson and I gathered this information. Now, the implementation domains, it's not just say, okay, I'm trauma-informed, let me as Dr. Fields go in here and do this. I think it's kind of a top-down approach if we're going to get this right in our clinics, that our governance and leadership embrace physical environment, collaboration, screeners, etc., and even the right kind of financing to kind of pull this off. Utilizing appropriate screeners, I'll click on those in a bit as well. I like to use the impact event scales, which is a 22 question kind of screener, but I will have a whole list of those that I'll show you when I get done with these slides before I turn it over to Dr. Johnson, that has, I think, 10 or 11 kind of that the VA recommends. And so when we refer to services, we want to have a screening, or when we provide services, we want to be able to talk about what the patients endorsed and what seems to be an evidence-based approach moving forward. And we want those instruments to be trauma-informed. So, I don't whip out the fields. I created this my own 5-question survey. I want something to have some data behind it so that my patients get what I hope is the best care that they can. Again, I already provided some examples, but one example I would provide just on top of that is I can think of one patient who has issues, who had a history of trauma, and we are very sensitive to work up to his blood draw and to talk with him about it, even the session before. And then I have actually been able to participate in those blood draws. So again, I look at it like we are not trying to fit a square peg in a round hole. We realize he has this history of trauma. And so we work our way up to it and talk with the patient about what we're going to do next. And we've even been able to do some relaxation with me, and then they come in and do the blood draw while the patient makes eye contact with me. So that's just one example of how we've tried to treat each patient with a trauma-informed kind of approach. As far as treatment, I did promise that I would show you guys a few things before we get to that. So I'm going to share let me find it if I can. Here is the impact of event scales. I told you I'd talk a little bit about scales, and those are the 22 of that, and you can find that online. So we'll let you see that. And then the other thing I wanted to show you, oh, well, Microsoft doesn't want to participate. Here it is. I don't know, can you guys see this? I don't know if I stopped the sharing and I need to restart it. No, can we see that?
Not yet.
Okay, let me share that. And okay, I think I did it. Yes, it can be done. So
Perfect.
these are, I'm actually not trying to bury the lead, but while I have this up, these are the psychotherapy approaches that we'll go over. And again, I highly recommend this PTSD site, as Dr. Johnson pointed out, the VA site. They'll give you a little in-depth description of each of these. I'll be talking about these as well. But what I really wanted to show you was these different adult PTSD self-report measures. And again, I talked about the impact of event scales. You can click on that. It'll tell you a little more about it, how to get it, some sample items. So I do urge you folks to give this VA website a good hard look if you're wanting to look at more trauma-informed care in terms of psychotherapy measures and find a measure that's a good fit for you. And then I also mentioned this. I accidentally hit stop share because it's a really tight squeeze in there. There it is. The Census concept of trauma and guidance for trauma-informed care. It's a nice resource that goes through the trauma-informed care approach, does a deeper dive into those things about how you could make your clinic more trauma-informed. So we'll stop that as well and get back to our PowerPoint. And here we go. Current slide. There we go. So PTSD treatment. Can you guys see this? Just making sure.
Not yet.
I'm sorry?
Not yet.
Okay.
Didn't come up.
Okay, apparently I did the same thing again. Sorry. Let me end that show and go back. I apologize for my lack of dexterity here going back and forth from screens, but if it helps any, nope, still didn't work. Share screen. Share. Okay, there we go. Let me get to it. Aha! All right.
Yes.
And from current slide. Okay. PTSD treatment. We're back. I promise I won't click off this again now that we're there. So a couple things to think about. Dr. Johnson talked a little bit about how communities, that there can be traumas and floods and so forth. So that's important that we take a community context as well. Help can look like, what does help look like? What starts with a screener, I think, and really making sure we got the diagnosis correct, and then doing some additional training for our staff and our providers, and working on appropriate sensitive treatment models. One thing that generally most of us do, most of my colleagues who work in primary care, take a CBT approach. And for our patients with histories of trauma, on the cognitive side, we can work on trauma reactions, imagine all kinds of exposure, reprocessing, fear logs, even constructive worry logs. We've done that as well for folks who have trouble with thinking about things at night. On the behavioral side, of course, exposure and response prevention, arousal reduction techniques. There's some data to support groups, although I've never had a lot of luck with it myself, just because I have trouble getting anxious people in a group. But I do want to just throw a shout out there that some folks are doing that, and there's some data to support that. Now, taking a deeper dive, something that's, I think, just in the past year or two I've learned about is written exposure therapy, also called WET for short, because everything has to have an acronym, right? But this is where patients write about their exposure experience. And when this first started down the pike, people gave it kind of a big old, that can't work. We've got to do like intensive, long-term treatment with folks. But actually what they're finding is that written exposure therapy in about 5 sessions, we can get some good results. And it essentially, if you think about prolonged exposure therapy, kind of Edna Foa's model, it's just repackaged in written form, where the patient writes for the exposure piece, and then it's kind of clinically guided and structured. And so while I wouldn't say I'm an expert in written exposure therapy, I would say that I've been able to incorporate some of that in my treatment in a primary care practice with 30-minute sessions. So I know there are some barriers there. Where I would generally refer out is if folks need, if folks seem to be a good fit for cognitive processing therapy, because this is more manualized, 12-session, hour-long, and I would send them generally to my colleagues down the hall. I have the luxury of having folks at behavioral medicine and psychiatry, and this is built around the premise that people organize information about their world in schemas, and that what they're doing is breaking down those schemas and doing some intensive work to reshape them so that folks can learn to trust, feel safe again, self-esteem, so on and so forth. And I already talked about FOA's work and this more recent kind of thing with cognitive behavioral practice, where we work to reduce anxiety, whereby one confronts situations, activities, thoughts, and memories that are feared and avoided. This is essentially prolonged exposure. It is manualized. It's generally 90-minute weekly sessions. Show of hands, who can do that? Not me. For at least about 10 times, so it's very intensive. But the focus is with patients who have really serious kind of PTSD symptoms, and it's psychoeducation, breathing, exposure, reprocessing, homework, exercising. Now, I will borrow some of this and try it in my own 30-minute sessions, but to say that I do prolonged exposure therapy in a primary care setting, that would not be true, but I do think it's helpful, and I can refer out and try to borrow some of that as I can. I now will mute myself and turn it over to my colleague, Dr. Johnson.
Yeah, so last and not least, as the physician, we like to prescribe medication. So this is sort of to kind of look at, well, what is available out there for us for medications as we see these patients. So as Dr. Fields was saying, our big thing, and we're kind of undertaking this now, is to kind of really start to look at uncovering some of these, the PTSD, and looking at these adverse childhood experiences going forward and kind of formulating a plan. So usually what I am, the patients I see, or if residents are checking out a patient to me, is that, we do some symptom management. We've got some mood issues and stuff. So kind of looking at the medications that we have available. Now, the one that nightmares, prazosin, which is an antihypertensive medication, has been used. Initial studies were quite good, that it can help with those nighttime events that maybe patients would have. They've got to be very, very careful, though. It can cause some low blood pressure, so anybody getting up in the middle of the night. Some follow-up studies were not as good, but the people that they did in the follow-up studies maybe weren't as sick as the initial people, so maybe there was not as much to gain in that therapy. So definitely it is, using prazosin is an option for those nighttime symptoms, the people having sort of night terrors and nightmares and flashbacks in their sleep. Now, two medications that are used is the sertraline and paroxetine, Zoloft and Paxil, have FDA approval to be used for PTSD. And what you're doing is you're looking at just sort of those mood issues, and really also the sort of hyperarousal issues that people have. And so, and that's really where our medications show their effects. But they don't, the avoidance and sort of the emotional numbing that patients have, maybe not as well. Other medications also is fluoxetine, or otherwise known as Prozac, has also been used. But it really, the sertraline and paroxetine are really should be the go-to medicines. I personally like sertraline the best. Now, the other one is the SNRIs, and venlafaxine has been the one that really has been used, has been studied, and one that people prescribe, and also is one that can be used. Its big issue, though, is missed doses, and sort of you can get some pretty bad withdrawal symptoms because of its half-life. But if patients are willing to, take this on a regular basis, it can help. We have placed here about benzodiazepines, and this was really the go-to for many, many years, and using benzodiazepines. And I know I've seen guys that are Vietnam vets who are on big doses of benzodiazepines and will be probably for the rest of their life. But we really, really discourage the use of benzodiazepines. Sometimes they are used in this really quick, limited use, but then they really have no place long term. Three other medicines to talk about. So the first one is for people who are just having a lot of issues, and we're really getting nowhere, is that the atypical antipsychotics, quetiapine and risperidol, have been used at really low doses and kind of find that nice level if you can help patients with their symptoms. And then last but not least is THC, is marijuana. So I can say that probably of my PTSD patients, all of them are using marijuana. And the studies for using marijuana maybe aren't as good. The synthetic version of THC has been studied in some trials and looks relatively good for helping patients with their symptom management. So this is something, I can say that almost all the patients that we see in our office with PTSD, marijuana is definitely something they are using. So one of the ones, and this was a bit new to me when I got reading about this, but then I've been kind of talking to some of my colleagues, is with eye movement desensitization and reprocessing, EMDR. And what this does is it is where patients go in, we're doing therapy, and there's really kind of a deep dive into memories, events, looking at those things that are causing distress, and then looking at adaptation skills and behaviors. It is a very, very in-depth process that then also uses eye movement with the patient focused on those distressing memories, and basically trying to kind of reprocess and relearn those things that cause that patient distress. And the work for it looks good, especially just kind of picking out some patients. Some patients are not going to be able to go in and just process stuff prior to the eye movement desensitization work. So I kind of look at this, that I pick out who would be good for this, and it does work. I've talked to some of my colleagues in private practice that have patients that have undergone this treatment, and they are definitely positive on the results.
Okay, so we're about to wrap up. I do want to say something about trauma work. First, again, as I mentioned earlier, communities and clinics can have trauma. We had a shooting at a local clinic here. Well, no, it wasn't a shooting. I'm sorry. We did have a shooting, but the case I'm thinking of is there was a woman who was stabbed, and she got in her car and drove to like a rural health clinic. And one of my colleagues who actually, she goes to the forum sometimes. I don't know that she'll be here this year, but talked about what that was like for the clinic, having a stab wound victim kind of come in near death. And many people in the clinic who worked in the clinic know this person, and just how traumatic that was. They ended up losing the patient. So shootings, stabbings, suicides, acts of God can create these very kind of PTSD symptoms in staff in the clinics when they experience this, or experience working with folks who've had traumatic things happen to them. And we as clinicians have to deal with the vicarious trauma from some of the things that we hear. And folks can suffer at a minimum from compassion fatigue sometimes when they hear so many sad, difficult stories, but certainly over time, burnout can be a byproduct. So I guess part of being trauma informed as well is kind of having your own internal compass to say how you're feeling and what's going on with you as you do some of this difficult work. So I did want to mention that as well, because that's an important part. Wanted to open it up for any questions for me and Dr. Johnson, and we sure do appreciate your time today.
So I'd put it in the chat box, but I will say it out loud now. One of the things that I've been seeing is I have a series of COVID nurses from our local hospital system. And there's so much going on. There's the trauma related to what they're witnessing. They're also traumatized by what patients do kind of after they leave. One of them was talking about a patient who'd been very, very ill and leaving and seeing him on the news, not wearing a mask, telling people it wasn't a big deal when they had a very different experience of his care. And your talk about ACEs had me thinking a lot about how all of them had some other trauma that was re-triggered by their current experiences. So I just wanted to share that and wonder whether you'd had any experiences or thoughts about that.
Yeah, I can start. I think a colleague and I actually did a study that's still, we're still analyzing the data, but one of the things we're seeing very clearly is that among our nurses, MAs, and clerical staff, we did the IESR, so the Impact of Event Scales, PHQ, and GAD-7, and all were higher than in a typical population. So folks are really struggling with coming to work during COVID, working, with patients who are positive. And then I think Dr. Rickard had a good point there that then people's, people come back from war and it's like, wow, they're a hero. They battled this difficult situation, and folks are battling COVID, and there's this undercurrent of, well, it's not that big a deal. And I think that matters. That matters to people, and it sort of, I think, sometimes makes them feel more alone and less supported if they're dealing with this and stressed about this, or if they've had this. And so that's a very good point about, the public perception and how some folks are very serious about COVID and its impact, and some folks are not. I don't know, Dr. Johnson.
We've had that in our office where we've had a lot of discussion among the faculty and kind of doing a lot of, I guess, sort of decompression, as part of our faculty meetings, and, a lot of sharing and things, and people are struggling. We've got people that have kids away at college, and so, they're having to deal with that. And then down at the level of the residents, where our residents do a significant amount of our inpatient care, and with our OB care, and being exposed to COVID, and then having to figure out, well, what does this do for my colleagues, and, what is going on? And then our staff, which most of our school systems here are home-based, and then our staff are rooming patients, but they're on the computer helping their children do Zoom homework as well, and their lesson plans. So, and then, of course, all of the financial things. So we've tried to pull together as a department and helping people out that are really, really struggling.
That's awesome. I've been trying to figure out, like our group, I think, has really done a good job with that. But the nurses that I'm working with are in the larger system where there is already a nursing shortage, and people are really worried about being able to staff the floors, and so they have the additional stress of, as one of them has really pronounced panic attacks, of worrying that if she's not able to function, she's going to get written up, because nobody can tolerate anybody being sick, and yet the very circumstances are creating the conditions where people are getting sick. And I don't know what the answer to that is. I see that as a systems issue. I would love to fix the system, and yet I don't even know how to go about that.
Yeah.
Yeah, it's tough. And I think, this pandemic has also shed light on some systems issues, kind of putting, I guess, safety and health of staff and clinicians and even patients. It's like, how do we manage that in the context of still needing to do outpatient visits and procedures and elective surgeries? And it's just, and then managing, as you said, emotions and wellness and emotional wellness of staff.
Yeah, I've had it. Probably the biggest place it's impacting. I do our nursing home care. I'm sort of the person within the faculty that does that, and the nursing home care has gotten really, really tough. Fortunately, my nursing home has only had a couple of staff and a couple of patients get coronavirus, but they've done okay. But our nursing homes are locked down. There's no visitors. I am required to get coronavirus testing now every 2 weeks. If I'm bringing any of my residents with me, and I'm now trying to figure that out, I'm going to have them tested as well. The patients, my one patient's 101 years old and just is like, what the heck is going on out there, and they're watching the news, and their family can't come visit them, and then the staff is strained, the patients are strained, and so yeah, it is really something. Now, we have an outside faculty member that does our other nursing home care for our other class, and their nursing home actually has had a significant coronavirus load, and it really, really went through their building hard.
Mm.
Yeah, I have a colleague that I talked to today, and earlier today, and he said he has signed 13 death certificates in the last 2 months, and he can't remember. He said that's probably what he would sign in a year. So it's a very, very different kind of time.
Yeah.
I do see us at the end of our hour, so I guess we will conclude. But can we continue to talk for just a few minutes as we conclude?
Yes, I'm going to go ahead and stop the recording. Thank you, Drs. Johnson and Dr. Field. I really appreciate this presentation. I really learned a lot today.
Cool.
Thank you.
And hopefully I can stop the recording.
I'll stop the share as well.
All right.